Hi, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Mike Berkowitz. I'm the electronic editor of JAMA and the JAMA Network.
We're going to talk about another couple articles from this week's release of JAMA Network Open. Remember, if you're watching us live, please leave your questions on Facebook underneath the video here, or tweet us at JAMA Network Open.
And be sure to share this with your friends as you're watching or afterwards.
Yep. And if you've got questions, we're going to do our best to answer them in real time, so please submit what you can.
What do we have this week, Seth?
A couple articles. First one we're going to talk about is the assessment of incorrect surgical procedures within and outside the operating room from the U.S. Veterans Health Administration medical centers.
Incorrect medical procedures. That sounds scary.
Right.
Tell me what they were talking about.
It does. So what they're doing, this is a follow-up study on two previous studies where they looked at how many incorrect procedures are done at the VA. Incorrect procedure is a pretty broad definition, and most of it refers to things like the wrong implant used, or wrong site, or say wrong level on the spine.
Okay, so it's not necessarily the wrong patient, or is that sometimes included, where you end up undergoing surgery that you didn't sign up for?
There were some that were for a wrong patient, but that was a pretty small fraction. Most of them were actually relatively innocuous, things like expired lenses being implanted by ophthalmologists, which is bad, and the authors point out that more than anything else, that's a problem that they're not following proper procedures and protocols, because it's basically a bad near miss.
And this is the VA system, and my understanding, Seth, is that based on the literature and also my experience in the VA system, the VA gets a really bad rap for quality when in fact it meets or exceeds quality standards for other institutions. So does this paper tell us anything about that?
Right, so that's exactly what this paper found. It found that the number one thing is compared to the data from the previous studies from this century, the rates are actually improving or holding about steady for how wrong or how common these wrong procedures are happening. And they're also well within and probably below the rates in the private medical industry. Their rates are here, I think, are from like 0.3 to 0.4 per 10,000, something like that. And we don't have as good data for the overall medical system as a whole, but it's somewhere from, they quote, 0 to 3.9, so well within that margin. Plus, one of the points they make is because of the VA, because of how it's administered, because of a lot of the scrutiny it gets, they actually probably have better systems in place to report a lot of these near misses or minor mistakes.
Got it. My understanding, based on some old data, is that ophthalmology and neurosurgery or orthopedics were often the worst offenders, only in the sense that the eyes are the same, and so you have wrong side surgeries with ophthalmology, and you can have wrong level surgeries when you're attacking L4 instead of L5 or T2 instead of T3. So is that consistent with what these investigators found?
Yep, that's pretty much what they found. The three specialties with the highest rates of incorrect procedures were dentists, ophthalmologists, and neurosurgeons, mostly again with spine surgery, as you said.
Okay.
And most of these, like I said, is ophthalmologists putting in wrong implants, spine surgeons operating at the wrong level, and dentists operating at the wrong site.
Right, so the dentistry aspect is new, because most health systems don't integrate dental services, but the VA has that.
Exactly.
And there was also radiology in here. Can you just say one more thing about that? Is that therapeutic radiology or diagnostic radiology? Does the paper say anything about that?
You know, I don't remember. I think it was mostly diagnostic and mostly on the wrong side, which is frankly something that I've noticed. You know, it happens sometimes. People have two of most things, and we take pictures of them. And I mean, I know I put in every time I'm putting in an order, I'm thinking, wait, is that the left? Is that the right? Is that their left? Is that my right? It's a common human mistake you can make. So we try to set systems up so we can catch these things before they happen.
Sounds good. So there's still, as in every health system, work to do in order to improve quality and safety, but things are getting better in the VA.
Yeah, and honestly, reading this, I'm more reassured than anything, and not for the VA specifically, although I did used to work at a VA as well. I'm not a specific VA apologist. But these rates are just generally, even with pretty expansive definitions of what wrong procedure means, the rates are pretty low overall, which is nice to know.
Which is good, and this is kind of, you know, just by title, an embarrassing aspect of healthcare, so it's probably good to get this out, understand that these are rare events, but still develop systems in order to prevent them.
Exactly.
Fabulous.
All right, so let's move on to the
What's next?
Yep, let's move on to the next one. This next one's called the Association of Elective and Emergency Cesarean Delivery with Early Childhood Overweight at 12 Months of Age.
Okay, so this is about delivery mode and childhood obesity.
Right, exactly. So what these authors did was they looked at a bunch of patients, a bunch of people who were born in Singapore, about 700 or so infants, what their mode of delivery was. Were they a regular vaginal delivery or a C-section? And then followed up with the patients a year later to see if they were overweight or at risk for being overweight.
Okay. And tell me about the C-section, because there's more than one type of C-section, right?
So I'm a simple ER doctor. So one of the things that was really interesting to me was how much you could parse about a C-section, what it really means. The accompanying editorial gets into this a bunch.
Okay.
But whether or not a patient in the study is exposed to a C-section, whether they had started labor or not started labor, the main thing that they got down to was whether it was an elective C-section, like it was pre-planned well before 24 hours before delivery,
right.
Or if it was something that happened because they either started labor or recognized a problem or went to the OR. And again, this is kind of an intuitive definition of what an emergency C-section means for a healthcare provider.
Got it. So I have a vacation coming up, right? It's holidays are coming. I want to take my week off. I may have schedule my C-section December 15th so I can take my kid with me at the end of the month, right?
Right. There you go.
Great.
Yeah.
And so what did they find? What's the bottom line, or what's interesting about this paper?
So the most interesting thing was that the only of those three groups, vaginal delivery, elective C-section, and emergency C-section, only elective C-section was associated with higher overweight rates at 1 year.
I see. Only elective C-section. So why would that be? Does that make sense?
Right. So we don't know exactly. There's a couple hypotheses that the authors and the invited commentary talk about, and some things that have been thrown around in a lot of other papers. Part of it might be related to some sort of stress response that happens during the labor process. The baby's being squeezed the right way. There's hormones that we either do or don't know about. Or it might have something to do with the gut microbiome and whether or not the infant who's being born is exposed to a certain type of natural flora.
And I assume that they adjusted for parental BMI in this, because there could be some confounding by which parents with higher BMIs are more likely, I don't know this for a fact, to schedule elective C-sections, and it's the genetic disposition that's passed along that would appear to be the mode of delivery rather than the genetics itself. So did they account for that, and did they discuss that?
Yep, they accounted not only for things like BMI of the parents, but also for things like education levels and other basic markers of socioeconomic status, and none of those really changed the relationships here, which is interesting.
Right. So this is just another piece of evidence suggesting that we should be taking cesarean section deliveries very seriously and not as a kind of a discretionary lifestyle choice, or is that over-interpreting these data?
I mean, again, I'm a simple emergency doc. I don't do C-sections very much on my own, but it certainly seems like the pendulum towards C-sections being more and more widespread might not be without some sort of downsides.
Right, and I understand C-section as being a quality measure within the obstetrics community, but as a simple general internist, I don't know where the status of that is.
Right.
Good to know. Okay,
Yeah.
Wonderful. And so what's up next?
Okay, last paper we're going to talk about today is clinical characteristics and factors associated with mortality in first episode infective endocarditis among persons who inject drugs.
Oh, so as an internist, I love infective endocarditis. Like syphilis, it's the great imitator. It's always a wonderful teaching cases, and this is kind of primary care bread and butter, at least for medical trainees who are taking care of vulnerable patients who are injection drug users who develop this not that unusual kind of infection.
Yeah. Although I will say, and I'm a bit younger than you are, and I probably haven't seen as much infective endocarditis, or I'm certainly missing a lot of cases.
Go ahead and rub it in, Seth. Okay.
Right. Well, you just learn so much more from these cases.
Right,
than I
exactly. Right. The only bed you don't learn one from is the one you sleep in, right? Okay.
All right. So what these authors did was they looked at about a decade of patients who had infective endocarditis at 3 hospitals in London, Ontario, and Canada, and only found about 370 episodes of first episode endocarditis among people who inject drugs. And they found a couple interesting things. First of all, a lot of these patients had hepatitis C. That wasn't the cause of their endocarditis, but not surprisingly, there's high rates of hep C among people who inject drugs who are sick.
Right.
As we've kind of known and understood for a while, most of these were in right-sided infective endocarditis, not on the left side. Although patients who had left-sided or bilateral endocarditis did worse. And what else? A lot of Staph aureus. A lot of it was methicillin susceptible, not methicillin resistant Staph aureus.
Okay. Wonderful. So a lot of that isn't terrifically surprising. I think we thought we knew that injection drug users or persons who use injection drugs will get right-sided endocarditis. I guess it's a little bit surprising or in a kind of an odd way reassuring that the epidemiology, the microbiology hasn't changed. It's still Staph aureus. It's methicillin sensitive rather than resistant. So that's good. So this is kind of reassuring, but does this break any new ground in particular?
So one of the things they look into is the patients who got operative cure or operative repair, basically who got surgery for their endocarditis. In general, these patients were sicker. It's a smaller subset, but they have some crazy names of things that I don't say a lot, like aortic involvement or aortic infection.
Right.
They had heart blocks from their endocarditis and other problems like that. And the patients who got surgery actually did better than the patients who didn't get surgery. It's double-edged sword. It's hard to know because there are some patients too sick to get surgery and therefore do worse.
Right.
But again, it's the patients who, most of the patients who got surgery were patients who had pretty significant indications to need surgery. So they're pretty sick.
So that's my question, is whether there's reverse causality in a way, which is that the people who are well enough to benefit from surgery are the ones who get it. Or let me put it this way, the people who don't die live to get surgery, and therefore there's a kind of an inverse association between getting surgery and reduction in mortality.
Right, like a survivor bias, which is one of the most interesting biases out there.
Competing risks analysis, which are really difficult to do, and I don't think they performed, which isn't a criticism, but it's hard to know what's really going on there.
It's really hard to study. Again, they got less than 400 patients in 10 years of experience. It's hard to do studies. We're not going to see an RCT of this anytime soon, or I'd be very impressed. They did try to correct for another thing, some of the usual comorbidities, or age at least. They also looked at who got referred to substance use treatment afterwards, which was probably some sort of, I don't know, extrapolated marker of how healthy the patient could be.
Right.
And the patients who were able to go to substance use therapy afterwards did do a little better as well.
Okay, and the authors put a fine point on that. I think they draw out that they think the contribution of this is that we're in the opioid epidemic era, which in this case obviously includes injected heroin. I guess it can include injected OxyContin too, but I assume it's street heroin. And that we're looking at the we're seeing not much of a change in the epidemiology of infective endocarditis in an opioid era on the streets of London, Ontario in this instance. The same reverse causality question comes up. People who survived enough to get the referral may have been healthier, so there may have been a selection. And as I think you know, there are statistical ways to manage that, whether it's a propensity analysis or instrumental variables. And I didn't see that in the study, but that could obviously be next steps to use with this data set.
Yeah, that's definitely some interesting places we could go to try to do some sort of risk adjustment with that.
Right. Okay, wonderful. So that's great. That's a good roundup for today.
Great. Great. Well, thank you. Be sure to check out these papers and more. The rest of the issue is at JAMANetworkOpen.com, and also follow us on social media channels, Facebook, Twitter, and LinkedIn at JAMA Network Open.
And thanks for checking us out this week. We'll be back next week with another Facebook Live about this week's JAMA Network Open releases, which are due out Friday at 10 a.m. Central Time. Thanks, guys.
Thanks.